We are going to have our next presenter, Miss Sandra, if I'm correct, right? Sandra Shi from Harvard, and she's going to talk about frailty in the Medicare population, and she's going to compare the Medicare Advantage population with traditional Medicare. Medicare Advantage is a private alternative to traditional Medicare, which usually includes a lot of other benefits than you're going to get from your TM plan. So there is a difference, and we're going to learn a little bit about it. Thank you, Sam.
So thank you so much for the wonderful invitation, Igor. I was presenting this work at GSA, this just past GSA, and the opportunity to interact a little bit. And honestly, I was just really excited about it. So my role, I wear kind of two hats. The first is I'm a geriatrician. So I actually clinically take care of older adults in a nursing home, including many who have dementia on my memory unit. And then in my second hat, my research hat, I leverage large cohort surveys and Medicare data to try to understand what's happening with healthcare and utilization on a sort of 50,000 foot level. And so I don't have any disclosures related to this presentation. I am funded by a GEMSTAR and an OEIC pilot. So my particular interest actually focuses on frailty, and in particular, because as a clinician, we recognize frailty as a syndrome of diminished physiologic preserve, meaning that older adults who are frail are more vulnerable to poor health outcomes. This might be something like disability or death, certainly cognitive decline, falls. But because it is a common risk factor for so many problems that are related to aging, we recognize it as a very good predictor of common health problems related to aging. Now, clinically, when I see a patient as a geriatrician, something I can do is a comprehensive geriatrics assessment. And here, this is sort of deliberately a little bit difficult to see. But you can imagine if I'm seeing a patient, I'm collecting all of this functional information about their activities of daily living, how much they're able to do these things unaided by themselves. Instrumental activities of daily living. Are they able to prepare their own meals, take their own medications, manage their finances? These are physical tasks. I'll ask patients, are you able to walk up a flight of stairs? Can you walk a block or half a mile? Sometimes we may do performance testing, for example, cognitive assessments. We might be able to measure their gait speed, how fast they walk. And the idea is a frailty index essentially takes a ratio of how many problems they have, and it normalizes how many problems they ask about. So the QR code here is an online version of it that's available. But essentially what we can calculate is what's called a frailty index. So the example that I kind of have up here calculated a frailty index of 0.27, which corresponds to mild frailty by typical kind of cutoffs. And the nice thing is it also gives us kind of domains of impairments or deficits. So for this hypothetical person that I plugged in, most of their domains of concern reside in mobility, muscle strength, and IEDL disability. But for example, they're relatively cognitive. So that you can imagine it's extremely useful for us as clinicians when we're evaluating patients and thinking about ways to intervene. Now, the other advantage of a frailty index is that it's extremely operationalizable because the deficits or the problems that you plug in, it turns out, can be quite flexible. And so this allows us to look at this problem on a broader scale. So one of the things that we did was we operationalized this in cohort studies. This particular one was the National Health and Aging Trend Study. And not surprisingly, if you build this in a cohort, and a lot of these surveys have the data of activities of daily living, comorbidities also can go into frailty indices. And you similarly categorize people out. What you see is that as frailty level goes up, then so does the risk of, again, poor outcomes like death, hospitalization. This is 1 year ADL disability and reported falls. So this is an extremely useful tool because for me, it's helpful because I can think about something on a 50,000 foot view level, but I also can translate that to a clinical level pretty easily in my head, at least. So one of the first things that we tried to do was look at this. Now, I mentioned we're using specifically the National Health and Aging Trend Study, and I'll tell you a little bit more about that in a second. But in particular, the reason this question is so important is that a lot of the Medicare data, in fact, most of the Medicare data that you're hearing about, and you typically will learn about, is Medicare, traditional Medicare, or fee-for-service Medicare data. Now, Medicare Advantage, or Part C Medicare, as it's also known by, is offered by private insurance companies. So basically what this means is Medicare is contracted out to a private insurance company. You might be Cross, it might be Humana, you might have heard of some of these names in the past. But basically, they contract out to a third party at a private insurance company, and they say, you take care of this person, we'll kind of pay you for it. And so from that point on, what this kind of leads to is problems with data standardization and availability. So Medicare Part C data is traditionally, it's a little bit harder to work with because you basically have data coming in from all these different private healthcare companies, and they might use data and collect different sorts of data in different ways. And so it can be a little bit tricky to work with. So historically speaking, traditional fee-for-service Medicare has been sort of easier to work with. You can just get it from CMS or Center for Medicare Services. It's fairly kind of standardized in a lot of ways, including costs, including what's covered, what's not. For example, Medicare Advantage covers dental. They kind of build that in on the revision. Those are not typically covered. And so it allows for traditional Medicare, because it's a little bit more available, it's a little bit more standardized, it's easier to work with. And so most Medicare studies have not really looked at Part C, or if they do, they look at a specific, like one specific HMO or one specific kind of subcontract. But in recent years, Medicare Advantage enrollment is actually rapidly expanding. It's doubled since 2010. It's now actually the majority of the Medicare population. So it's actually flipping. It's gone from being the minority to the majority. And we also know that this is from other data, but it's been demonstrated that a greater proportion of racial ethnic minorities and also dual eligible Medicare Medicaid beneficiaries are enrolling in Medicare Advantage. So as we think about the populations that we're studying, especially with attention to those with racial ethnic minorities, it becomes a problem if we're only looking at the traditional Medicare population, because it's not actually as generalizable as we used to think it was. Now, historically, Medicare Advantage beneficiaries, they've been healthier. And so we've been able to say, well, we're looking at the sickest population. That's really what we're interested in. Again, that's not necessarily so true anymore. There are special needs plans that cater to specific conditions, including dementia, for dual eligible beneficiaries. So the question that we asked was, well, are Medicare Advantage beneficiaries less frail when we're looking again kind of global health measures than traditional Medicare beneficiaries? So we're leveraging the National Health and Aging Trend Study. It's actually a longitudinal, nationally representative survey of older adults. The total sample is about 8,000 people, and this actually includes people in nursing homes, assisted living communities, etc. And what they do is they go to older adults, they survey them once a year, as long as they're still in the survey. They actually interview them and a proxy if available. And they do cognitive assessments as well, which we'll get into a little bit more detail in a moment. So we took this particular survey, it's linked to Medicare claims. Now, if somebody was in Medicare Advantage, it doesn't give us all of the claims information necessarily. What it tells you is that they were enrolled in Medicare Advantage. So I wouldn't be able to do, again, the details, the finer details of what exact care they were getting while they were in Medicare Advantage, but at least I can see what they were enrolled in. And so this allows us to compare, again, the Medicare Advantage to the traditional Medicare population on a broader level. So I excluded folks that were non-community enrolling, and this is the 2015 sample. So we're looking at about 7,000 people. A handful of people either didn't have insurance information leakage for the particular month that they were being surveyed, and then another small handful just didn't have enough data to measure frailty at baseline. So essentially we ended up with a cohort of about 7,000 people. And so this is the population that I'm going to be discussing a little bit. So the first thing we looked at was the sociodemographics. And again, this is sort of trying to validate what we already know from other populations like the Medicare beneficiary survey. And what we see is indeed that racial and ethnic minorities are disproportionately enrolling in Medicare Advantage. And so, for example, in particular, interestingly, other races are only about 5% of traditional Medicare, they're 12%, 12.3% of Medicare Advantage. I should also mention, because of the way that NHATS does their surveys, these are weighted survey percentages. And so these percentages don't always necessarily add up. And then, of course, interestingly, one of the things that in NHATS also was whether or not the beneficiary speaks the non-English language. This is just on the border of significance, but there is a tendency for those enrolled in Medicare Advantage to be non-English speaking primarily. In terms of income, this is actually either self-reported or imputed based on other socioeconomic considerations in NHATS. But generally speaking, again, you see the pattern that Medicare Advantage beneficiaries tend to be of lower income, and they're definitely, if you're looking at the bottom here, it's a little hard to see, but dual eligible status, Medicaid eligible, this is 8.3% traditional Medicare, 14.5% Medicare Advantage. So again, sort of validating what we know from prior literature, that the Medicare Advantage population is certainly tending to be the lower socioeconomic status and a higher proportion of racial and ethnic minorities. So next we looked at, again, the Frailty Index, which I mentioned specifically we're using a Frailty Index here, which spans multiple domains. And interestingly, it's actually contrary to what we were expecting. It actually looks like Medicare Advantage has more frailty than traditional Medicare. And again, this was unexpected because typically we thought that Medicare, traditional Medicare tends to have sicker patients. And this is actually, at least by just pure frailty, not necessarily what we're seeing. It tends to be actually that Medicare Advantage beneficiaries had tended to have more moderate and even severe frailty. And there's a physical, purely physical function-based frailty or phenotypic frailty. We also assess this. Similarly, those with frailty, those with Medicare Advantage tended to have high proportion of frailty. And we looked at what could potentially be sort of driving this frailty or contributing to it. Well, it certainly seems that those with the IDL disabilities and also the physical function scores are really here coming out to be more significant. That overall, those who were enrolled in Medicare Advantage had worse physical function than those that were enrolled in traditional Medicare, at least at the time that the survey was being done and all of these measures were taken. And then, of course, we were interested in dementia. So I should take a brief moment here to mention that here dementia is being categorized by a specific algorithm that's actually similar to some of the other algorithms we've seen. NHATS uses its own algorithm, which consists of a 10-word immediate delayed recall, orientation, and then a clock draw. And then it standardizes in the population. So if somebody had greater than one standard deviation in a specific domain, then that was considered possible dementia, and then 2 or more deviations from the mean were in 2 or more domains, was considered probable dementia. But again, when objectively measured with these cognitive assessments, we're also seeing that those enrolled in Medicare Advantage actually tended to have, I would say, at least worse cognitive performance, but by their labels and NHATS, possible or probable dementia. One thing I will mention, the one comorbidity that seems to be less common in Medicare Advantage is cancer, by far. And this was actually pretty prominent, but 27.6% versus 23%. Essentially, traditional Medicare patients do tend to have higher rates of cancer. So thinking a little bit more on this dementia population now, and again, kind of zooming in on this, just the population of possible or probable dementia. What we then did is we tried to see, well, do these disparities in racial and ethnic identities still persist? Do income disparities still persist? Granted, we're looking at a smaller sample size now. Interestingly, the racial ethnic differences do still persist. Again, it's actually particularly prominent for the other race, and I should take a moment here to mention other race here. It's literally anything that is not white, black, or Hispanic. So this includes Asian, this includes Islander, this includes Native Hawaiian, Alaskan, etc. And so, interestingly, now the difference is 10% traditional Medicare, 22.8% Medicare Advantage. The dual eligible status is actually no longer statistically significant. There's a little bit of a difference here, but again, it's actually not as prominent as was the overall population. Again, when we looked at frailty now, the differences in frailty also are basically no longer statistically significant. You could argue there's maybe a little bit of a trend in maybe because power here, but generally speaking, the only domain that really remains significant is IADL disability, and this is defined by whether or not somebody is helping somebody with their instrumental activities of daily living. And this is an interesting aspect that we specifically kind of want to understand. What is the lived experience of these patients? And one of the really wonderful things about NHATS is that it really characterizes the social participation in the lived environment of the beneficiaries and the participants very well. So on the top line here is what I'll call cohabitation status. So essentially what this is asking is the person living with someone else? Are they living by themselves? Are they living with a partner? Are they living with maybe a partner and others? Here could be a roommate, it could be adult children, it could be just any kind of other category. And what we see is that, interestingly, for those who are living in Medicare Advantage, there does seem to be a trend that they're living with other people. And I don't have it up here, but kind of when I was looking at it and what kind of gets bucketed in there, it does seem to be that they tend to live with adult children more. So this might be a population that's actually, for some reason, they're moving together, they're habitating with other people, maybe suggesting that there's a little bit more of a social support system that's in place for them. And so, and the other measures here, I'll just kind of quickly point out, when we're looking at things like social integration or social isolation, and then other measures of social participation, like whether or not they're going out visit family or friends, going out for employment, attending group activities, and whether we're not finding anything significantly different there. So the last thing I'll mention with this specific NHAT data set exclusively is that we did also wanted to look at baseline frailty may be different between Medicare Advantage and traditional Medicare population. Is there a difference in the change of frailty? Because one hypothesis would be, well, Medicare Advantage, I mentioned, it covers vision benefits, it covers dental benefits, it covers a lot of other potential health benefits. Is it possible that this is maybe delaying onset or progression of frailty in that population? And so 1 year later, in the next NHAT survey, when they go back and we measure frailty again in these participants, what we were wondering is perhaps Medicare Advantage able to delay the progression of frailty. And what we're saying is that's not necessarily the case. There's really no differences between these two populations when we look a year later in their degree of frailty. So whatever's happening here is actually quite steep. And the adjusted estimates here, just so I'll quickly mention, it's adjusting for age, sex, baseline of status of whatever frailty the person had, age, cohabitation status, eligibility, et cetera. But even the unadjusted difference, you can kind of eyeball and see that there was really no difference there. So everything that I mentioned so far has been using NHATs and what I would call a survey-based, or almost, it's trying to approximate a clinical assessment of frailty that a provider would be able to do. But obviously that's not always available. And so one of the things that our group has done is develop a claims-based frailty index. And so this is entirely using Medicare claims data. It is using entirely traditional Medicare claims data, but what this does is tries to estimate in deficit accumulation frailty index. It's been externally validated against the CFI for various assessments. The code, if anyone's interested, is available via this QR code. But it has been independently validated to be correlated or strongly correlated with clinical frailty assessments. But what this allows us to do is kind of try to examine this idea of frailty, but without having that immediate kind of clinical assessment, which can be very difficult to find, and really just examine things on a broader Medicare population level thing. So the first thing that we wanted to look at was whether claims-based frailty might help us understand dementia severity, because dementia severity is something that's not captured in claims data very well. In fact, dementia is also arguably not captured very well in claims data. But because a frailty index sort of approximates the functional status of a person, and one of the strongest predictors, or one of the strongest ways that we measure severity of dementia is with functional status, then actually using NHATs, what we could do was essentially look at whether a claims-based frailty index could be used to identify people that are moderate or severe dementia. So we operationalize fast staging to categorize people into either moderate dementia or worse. And then we use a claims-based frailty index and essentially try to find a cutoff that would help achieve a relatively good sensitivity and specificity for what we're calling moderate dementia here, defining as fast stage or worse. And using this cutoff, what we were able to see is that, again, purely using claims data, that it was still correlated pretty strongly with needing medications or somebody being on medications for their dementia with mortality in 2 years. This is a suppressant L5 because the numbers are low, but also with a nursing home admission to long-term care nursing home in 2 years. And so there's the potential for being able to use claims-based frailty to actually try to approximate the degree of frailty, meaning whether somebody has mild or more moderate or severe dementia within Medicare claims, which is exciting. And then the last thing I'll point out is that we do recognize that there's definitely an overlap in these. And so this is just using Medicare, fee-for-service traditional Medicare data. We've created 4 categories here. The first is those that have no dementia or frailty, sort of the healthy population. Then there's a category that had dementia but no frailty. Again, you could think of people maybe they have mild dementia. You could think of the next category is those that just had frailty, no dementia, at least within Medicare. And the last is the overlap kind of population. And so here we're specifically interested in outcomes. The first is healthcare costs, and something like, and then the next is also a more, I would say, person-centered metric, which is days at home. And what this means is how much time is somebody actually able to spend out of the hospital, out of a nursing home, out of a skilled nursing facility or emergency department. Are they actually ideally sort of at home in the community? And so not surprisingly, you can kind of see that for the really healthy population that has neither dementia nor frailty, mortality is fairly low for them a year. And then for the category of folks that have dementia but no frailty, at least by our claims-based metric, mortality is closer to 12%. For the overall population, it's not surprisingly the highest mortality rate, or one-year mortality rate of 1%. And then that measure of days alive out of the hospital and SNF or time at home, how long are they actually able to be at home and kind of stay home, not have to go to the hospital or to a nursing home? Then certainly that as sort of these conditions go on with frailty and dementia, or you could argue with moderate or severe dementia, that we're observing the shortest amount of time at home. So this is tenfold to see. Now, the interesting thing was when we looked at annualized 1 year Medicare costs, we were a little surprised to find this. So at first we expected that perhaps with frailty and dementia, you would have the highest amount of cost. But in fact, certainly what we're seeing here, first of all, I'll mention is that frailty seems to be the stronger driver of Medicare costs in this population. That those with dementia but that didn't have frailty, overall their costs are actually fairly comparable to that population. But when we look at the population who have frailty and dementia, the mean costs actually seem to be lower than the population that has frailty but no dementia. And so we sort of hypothesized there might be maybe two things going on here. One is we saw earlier that this population has higher mortality. And so this is not adjusting for mortality. Obviously, if somebody is dead, they're no longer accruing healthcare expenditures. And so that could be one possible related reason. And that's also sort of justified. The black bar up here is hospice, and we definitely see higher hospice use in this population. The other possibility is that you have to think about, well, what are the drivers of frailty? Why is somebody frail? And so if somebody is frail with dementia, then it might certainly be the dementia that's driving their frailty, their poor physical function, et cetera. If somebody's frail and doesn't have dementia, then their drivers are probably more likely to be things like cardiovascular disease or maybe cancer. And those tend to be very high cost kind of drivers of high costs in our healthcare system as a whole. And so it might be sort of reflecting some of the difference here. So in summary, frailty and dementia are obviously parts of in our Medicare populations, but particularly in the growing Medicare Advantage population, which should be looked at more closely in the future. We certainly have plans to do that. It's going to be a little bit of a learning curve, I have to admit, because we're not used to looking at that data, but I think the time has come for us to look at it. There are measures, in particular claims-based frailty indices that can be used to estimate dementia severity, help approximate things like functional status, which is work we haven't been able to examine closely. But in Medicare claims, both of these predict worse outcomes, and trying to understand the interaction and the overlap between both is going to be really important. And that's it.
Thank you, Sandra, for that interesting presentation. Now, as serendipity would have, a couple of years ago, I did pretty much the same thing with the health and retirements. So I didn't do a frailty index because that takes too much time. I didn't want to take too much time. I just took a bunch of health variables, a bunch of social determinants of health, and I said, well, I need to rewrite my last paper because of this. Now, but the answer is no, but it did find some very similar findings and also some possible explanations. So one of the things that we saw was that over time, especially if you don't lump these people together, if you go year by year, and you can track them along using the Medicare denominator file. They rename it every couple of years, but the denominator file or the enrollment file doesn't care what you got enrolled in. It tells you are you enrolled or are you not. We see that although historically, right, the Medicare Advantage population, it's what your presentation says, right? It's more healthy. The key word is historic. Over time, it does seem like the health status of people are converging. And that makes sense because Medicare, traditional Medicare is very expensive. It's expensive, it's not a cheap program. And one of the things that Medicare Advantage promises is savings. Now, we're dealing with older adults. So older adults aren't very good with change. Right? It's not very popular around. Anyone remember their grandpa tried to get him to do something new that doesn't always work out. So, hey, try this new healthcare plan. They'll make you feel good and they'll be cheap. Right? Right off the bat, that may not be a good advertising strategy. But over time, as people move over to Medicare Advantage, as people use Medicare Advantage, as people don't die in Medicare Advantage and spread the news, the nature of the demographic profile that signs up for one plan versus another changes, and what we expect to happen also changes. Now, the good news is that we now have claims for Medicare Advantage available directly from the Centers for Medicare and Medicaid Services. They have included all the information that you get in traditional fee-for-service claims, with the exception of cost information. So if you want to catch those Medicare Advantage plans and try to figure out which ones are actually cost effective and which ones aren't, well, no, you can't do that. They don't want you to do that. All right, but the data for health is widely available, and it's on the chronic conditions warehouse where you can order everything in one place for lots and lots of money.